for joining me today. In this video, we are going to go over comprehensive psychiatric assessment. How we're going to conduct a comprehensive psychiatric assessment. Comprehensive psychiatric assessment is a systemic biopsychosocial evaluation that integrates medical, developmental, psychological, social, cultural, functional information to establish an accurate diagnosis, safety, assessment safety, formulate a differential diagnosis, develop individualized evidence-based plan. It serves as a fundamental of a psychiatric plan and should be conducted during the initial evaluation and updated throughout the treatment. Comprehensive psychiatric assessment include the objectives and subjectives. Objectives include the assessment, comprehensive psychiatric assessment. The goals are to establish a rapid and therapeutic alliance with the patient, identify the patient's present concerns, obtained throughout the psychiatric and medical history, to perform a comprehensive medical status examination, to identify psychiatric, medical, and substance disorders, to assess suicidal, homicidal, violent, and safety neglect risks, to determine a psychosocial stressor and protective factors, to develop a DSM-5 treatment criteria diagnosis and biopsychosocial formation, and to create an individualized treatment and follow-up plan. For components of a comprehensive psychiatric assessment include: first, to identify the information, to identify the patient. We wanted documented patient name, that is the first thing, patient name, medical record number. We want to identify the patient name and medical record number, date of evaluation, age of the patient, gender of the patient, identity of the patient, preference pronoun that the patient prefer, race and gender, primary language that they prefer to receive the education, primary if they are also language, if they are married, if they are in a relationship, occupation, education level, living condition, medical emergency contact, referral resources, source of the information, because sometimes the patient cannot give this information. Maybe they are in dementia, having a dementia or cognitive impairment. Maybe they are children, so we want to write down the source of the information, where we get the information from. We also want to document their rehabilitable of the history. Then chief compliant. Chief compliant is the primary concern that the patient came to seek help. You want to document the patient primary concerns in their own words wherever it's possible. For example, if the patient tell you, I have been having a depressive for several months and cannot sleep. So they told you two symptoms. I have been feeling depressed for several months and cannot sleep. They told you the duration and two symptoms, that they cannot sleep and that they are having a depression. So they have a two combined in one visit. Then next will be the history of the present illness. That provides a chronological description of the current illness. That includes the symptoms onset, when do they begin having the depression, when do they begin not sleeping. This is several months ago, but when, which month, duration, several months, how many months? We want to be specific. Frequency, do they have this depression every day, every month, every week? What is the frequency? Severity of the symptoms, progression, is the depression getting worse, is the sleeplessness getting worse? Participating events, what make it worse? Aggression factors, aggravating factors, what make the more severe? Relieving factors, what relieve the symptoms? Previous episodes, do they have this before this several months ago? Functional impairment, how that affected them? Their work, is this affecting their work, their relationship, their education, their goals? How do that, with their contact with their social, do that affected them? Functional, is this affecting their ability to function? Previous treatment, if they have been treated this before. Medical, if they taken medication, are they compliant with this medication? Recently, psychosocial stressor that cause this depression or sleeplessness. Then we want to review the psychiatric symptoms. Psychiatric review of the symptoms. We want to screen symptoms of a depression. Because if somebody say depression, are you feeling sad? How's your appetite? You want to dig more for the depression symptoms. We want to see if they are manic, hypomania, anxiety, panic attack, if they have an OCD symptoms, if they have a trauma related to these symptoms. Psychosis, are they having any psychosis? Eating disorders, sleep disorders. Do they have sleep disorders before, or they are having a symptoms? They told you they have a symptoms, but do they have a sleep disorders? Cognitive impairment, how do that affect their cognition? Substance usage, are they using any substance that caused them to have the depression and sleepless, affected their sleep? Psychiatric, we want to assess the past psychiatric history, and we want to document previous psychiatric diagnosis, previous psychiatric treatment, previous hospitalization for psychiatric, and then we want to ask them which day We want to include the previous hospitalization, the days, the facility, the reason that they admit to the hospital, the length of stay in the hospital. Then we want to assess the previous emergency department visit. We want to assess any suicidal ideation, and we want to document the method, intent, medical severity, treatment, they've been treated recently, medication that they taken for it, any injury, violent aggression history. We want to document it and assess and evaluate previous psychiatric and psychotherapy that they had. For example, if they had cognitive behavior therapy, deductible behavior therapy, family therapy, interpersonal therapy, and how that worked for them, and the reason they had it. Previous psychiatric medication, have they ever had any psychiatric medication? For each medication, we want to know the medication name that they had, dose, duration, clinical reasons that they've been prescribed for that medication, any side effect that they had with the medication, and the reason they discontinued the medication. Then we want to assess the medical history. If they have any medical history, do they have a chronic medical history? Do they have a surgery? Do they have been hospitalized for medical reasons? Are they allergic to any medication, any food? Do they have any allergies? Are they taking current medication for medical reasons? Are they taking any supplements or over-the-counter medication? And what is the reason they are taking it for? We want to also review and assess their immunization history. Common medical conditions that associated with psychiatric symptoms include thyroid disorders, diabetic, neurological disorders, autoimmune diseases, sleep disturbances, sleep disorders, chronic pain. All this can cause psychiatric symptoms. So we want to evaluate those. Then we want to assess and evaluate if they have substance usage history. So for the substance usage history include assessing each substance separately. We want to assess each substance usage separately. That include alcohol, nicotine, cannabis, cocaine, caffeine, methadone, opioid, hallucinogenics, sedative, energy drink. For each substance usage, we want to use the age at the first time they used that, what age they were when they began using that, how frequent did they use this substance, quantity that they use, the route that they use the substance, the duration, last time they used this substance, any withdrawal symptoms that they went through before, any treatment that they had with this substance, previous treatment. We want to use the validated screening tools when it's appropriate. For example, we want to use ARAT-C, GATE screening tool, DAST-10 screening tool, We want to also evaluate family history, their family, their parents, their siblings, their close family members, if they had any psychiatric disorders such as depression, bipolar, schizophrenia, ADHD, if they had substance history usage for their family and that can affect the person, if they had ADHD, autism spectrum, if any of their siblings or the family had that, if they had that themselves or if they have that themselves, then we want to assess the medical conditions that they have, such as thyroid disorders, diabetic disorders, cardiovascular disorders, neurological disorders. Then we want to assess the developmental history. And developmental history include a prenatal history, birth history, developmental milestone, childhood illness, learning disorders that they have, behavior concerns that they had. Then we want to assess the social history. Social history include the childhood environment, education, employment, medical, military service, relationship, if they have children, their living situation, financial stressor, legal history, trauma history, legal history. Are they immigrant? Are they went to prison? Are they in court hold? Legal history, trauma history, any PTSD history. We want to assess that. Childhood neglect or abuse, spiritual and religion. We want to assess and evaluate how do they practice, how did that affect these symptoms, or how do they deal with the symptoms, how they cope with the symptoms, cultural identity that they identify, social support, if they have a social support that help them to cope, to seek resources, habitual habits and recreation activity. What activity do they enjoy? What activity do they like to do? Then we want to do the review of systems. We want to review the body. First, we want to review the psychiatric review for psychiatric review. And then we want to assess the medical systems that include the cognition, cardiovascular, respiratory assessment, GI systems, GU systems, muscle and skeletal systems, neurological systems, endocrine systems, and then we want to evaluate and use more deeply for mental status examination. Mental status examination, we want to assess the appearance. Are they groomed well? Can they groom themselves or dress themselves? Their hygiene. Some of the psychiatric conditions such as depression, people neglected themselves, their hygiene will be lower or poor. So we want to assess their appearance, if they are groomed well, if their hygiene is good, if their clothes is okay, if they are having eye contact, if they appear appropriately to their age. Then we want to assess the behavior. Are they cooperative? Are they guarded? Are they agitated? psychosocial activity, abnormal movement, speech. We want to assist their speech if it's the speech rate, volume, tone, rhythm, frequency, and then we want to assist the mood, patient, objective emotional experience. We want to assist also their affect. We wanted description of the range, intent, stability of the affect, congruent with the mood that they describe. Then we want to assist the thought process. For example, if the thought process is linear, goal directed, circumstance, tangential, fight of ideas, loss of association, thought block. We want to assist the thought content. We want to assist if they are having a delusion, obsession, suicidal ideation, homicidal, paranoid, preoccupied. We want to also assist their perception. And the perception assessment include the hallucination, delusion, depersonalization, derealization. We want to also assist their cognition. We want to evaluate, because many psychiatric conditions affect the cognition. They affect the, we want to evaluate the alertness, orientation, attention, memory, language, executive function, abstractive thinking. Many psychiatric conditions and disorders affect the person's cognition. So we want to assess which area is affected. Insight, we want to assist their insight if they are aware of their situation, their illness, how they describe their condition and what is happening. If their insight is good, fair, poor, absent. Judgment, we want to assist the judgment. We want to evaluate decision making, understanding of the consequence. We want to also assist the suicidal ideation. We want to assist if they are having a passive suicidal ideation, active suicidal ideation, because that decides the decision we make. If we wanted hospital, if they have active suicidal ideation, we have to hospitalize the patient and stabilize the patient. If they have intent and plan, if they have means to do, if they have a previous attempt, if they are paranoid and their behavior, if they have perpetrated behaviors, if they have protective factors that help them to cope with the stress, and if they have a goal for the future. Dynamic, we want to assess if they are dynamic, static, risky factors. Then we want to assist the violence and homicidal risk assessment. We want to conduct the violent and homicidal risk assessment, and that assessment include homicidal ideation, intent, plan, access to the mean, impulsive if they are impulsive and they want to act on their impulsiveness. Are they having a substance intoxication, or are they with it? Are they having a command hallucination? Because people who have a command hallucination, they are hallucinating. So that is why do they are having these risks? That is what we assess, and then we want to assess the physical examination. We want to do the physical examination and we want to document the physical examination. We want to check the vitals, height, weight, body mass index, general examination from the heart, from lungs, hearts. We want to assess all the organs. We want to also assess the neurological examination. We want to conduct if that's applied to the person, especially if they are having a depression and sleepless nights. We want to also assess and evaluate the medical related findings or any medication that affects, such as if they are taking a medication and tremors, if they have enough tremors, if they have a rigidity because psychiatric medications and alcohol withdrawals and benzodiazepine withdrawals can cause them tremors, rigidity, if they are having any EPS symptoms, extrapiramidal syndromes, if they are having a tardive dyskinesia symptoms, we wanted evaluate the lab and diagnosis evaluation. We want to conduct the lab and diagnosis conditions. We want to conduct the lab and diagnosis evaluation, and we want to complete a base study. And those common base study include complete blood count, comprehensive metabolic panel, thyroid stimulating hormones, hemoglobin A1C, folic acid, vitamin D, vitamin B12, lipid panel, liver profile, pregnancy test, urine screening for drugs, proteins, if they have kidney failure, because the kidney failure will affect how we prescribe the medication. We will also conduct additional study when clinically indicated. This additional study include electrocardiogram if they have cardiovascular conditions. We want to also conduct electroendocrinological. We want to do brain imaging. We want to screen diseases such as syphilis, HIV, autoimmune diseases, and then we wanted a list and conduct differential diagnosis. We want to consider primary psychiatric conditions, medical conditions that can cause the chief compliant. Primary psychiatric conditions that can cause the chief compliant. Medical conditions or disorders that can cause the chief compliant. Substance usage disorders that can cause the chief compliant. Medication side effects that may cause this chief compliant. And then we want to conduct DSM-5 treatment criteria diagnosis formation that include a primary diagnosis, secondary diagnosis, medical diagnosis, and psychosocial stressor and functional impairment. Then we want to conduct the biopsychosocial formation that include biological factors that cause this chief compliance, such as genes, such as medical illness, substance illness, neurological illness. Then we want to conduct and assess the psychological factors that can cause the depression and sleepiness. We can assess the personality, we can assess coping mechanism, trauma history, defensive mechanism, and then we want to assess the social factors such as family, employment, housing, financial, relationships, cultural influences. Then we want to set up a treatment plan. The treatment plan include the psychopharmacology, psychotherapy, lifestyle recommendations that we want to give, personal education. So pharmacotherapy include the medication that we want to prescribe, the dose that we want to prescribe, titration schedule, mandatory parameters, mandatory paramedics that we wanted schedule if we wanted to lab monitor for the medication that we are prescribing, side effects, and then psychotherapy that we want to recommend for the patient that includes the cognitive behavior therapy, deductible behavior therapy, interpersonal therapy, family therapy, depending on the patient situation and the symptoms that they come up with. And then we want to conduct the lifestyle recommendation that we want to give the patient too. Lifestyle recommendations that we want to consider include the sleep hygiene, exercise, nutrition, stress management, substance cessation, patient education. We want to give the patient education, and this education is that patient education that we wanted discussed with the patient include the diagnosis. We want to educate the patient about the diagnosis. We want to educate the patient about the medication benefit and risks, side effects that potential side effects that they watch for, warning signs that they have to watch for, and then emergency resources that they can contact with if they have any side effects with the patient or if they have any suicidal ideation. Safety plans that we want to set up that include crisis hotline information, means restriction if they have means to harm themselves or others. We want to also emergency, we want to go over and discuss with them emergency contact that they can talk to and discuss with any concerns that they have. Follow-up appointments, we want to set up follow-up appointments, and the follow-up appointments include specifically, we want to be specific, it include follow-up intervals. Do we want to see the patient next week, next month, next 2 weeks, next 3 months, next 6 months, next year. Follow-up appointment intervals. And then we wanted also write down and let the patient also know the lab monitoring that we are going to conduct in the follow-up appointment. Medication monitor, because we have to monitor the medication. If the patient is taking the medication, we want to know if this is working for them, what kind of side effects they are having, if they having any side effects. We want to also follow up if they are taking their medication as you prescribe them. We want to also see how they doing with the psychotherapy referral, if you refer them, if you are conducting, if they are working for them, the coping skills and education that you give them, is this working for them? Do they benefit from it? Do they want to change it? You want to be also refer them specialist consultations if they have any medical or other psychiatric conditions, if you want to refer them specialists. And then you want to also follow up with the emergency precautions. For summary, every psychiatric evaluation must include comprehensive societal and violent risk assessment, correlate information from the family, collecting from the family and gathering from the family and from the caregivers, if they are child or if they are cognitive impairment, and previous medical records can substantially improve the diagnosis accuracy. So if you gather information from the family, if that is possible, the family, first you have to get permission from the patient if they are okay with that. So if you can gather different resources, different avenue of the data, will help you to get accurate diagnosis. You want to also rule out medical and substance usage disorders before you diagnose the patient with the primary psychiatric disorder. You want to rule out if there is any other medical conditions or substance usage that causes this chief compliant before you diagnose the patient with primary psychiatric disorder. Functional impairment is required in functional impairment is required for the most DSM-5 treatment criteria psychiatric conditions. The mental status examination reflects the patient's current mental function, where the history reflects the longitude of the information, how progress, what was the episode and what was happening to the patient. That is the history. However, the mental status examination will show you the current mental function of the patient. Use a trauma-informed, culture-responsive, and patient-centered approach throughout the evaluation. Although psychosocial formation guide individualized, evidence-based treatment plan. A true biosocial bi, true biopsychosocial formation guides the individualized and evidence-based treatment plan. Thank you for joining me today, and I would love to see you in my next videos. Please subscribe and join me again. Thank you.